Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. We've had a lot of, I tell you this all the time, we have a lot of, requests and questions relative to minimally invasive techniques and also to pain management. So what better group can I bring to us but these two wonderful doctors that are sitting in front of me, Dr. Charan Donkor, who is the medical director and surgeon at Westside Regional, I know, and you're a Broward surgical specialist, correct?
Yes.
I got it all in, correct?
Yes.
Okay. And we have Dr. George Semien, who is the chief of anesthesiology at Westside Regional Medical Center. Welcome, doctor.
Thank you very much for having me.
Good to have you here, sir.
Thank you.
Dr. Donkor, when we last spoke with you, I made you aware of the fact that the people out here, they're very inquisitive, and really, I don't know whether it's fear or the will to receive knowledge, which I think is both. They really don't like three things. I mean, none of us like it, but that's the way it is. They worry about cardiac disease, they worry about cancer, and they worry about surgical issues. And when I think of surgery, they always think of cutting, pain, and bleeding. Now, that's why I like to bring people like yourself to the show, because minimally invasive techniques mitigate a good amount of the problems and the fears of the people who are watching us. So let's talk about I know you do a lot of hernia, gallbladder, minimally invasive procedures, but let's just talk about the whole concept of minimally invasive surgical techniques. Go right ahead, sir.
Great. So, traditional surgery is open surgery. Those two terms are interchangeable. And basically making an incision, which is a large incision, or the incision appropriate enough to get the surgery done without using small instruments, just using your hands in the technique as it was developed over time. Minimally invasive surgery is actually a very fast-growing specialty within surgery, and that's actually using small instruments, small incisions in order to complete basic to complex surgeries with small incisions, and what that does is it decreases postoperative pain, reduces surgical site infections, increases your ability to get back to work, reduces your hospital stay. So there's a lot of benefits to minimally invasive surgery.
Well, you hit on every one of them, and we're going to get back to you in just a minute. Dr. Semien, with reference to anesthesiology or anesthesia itself, a lot of folks, I don't know what it is, they have a fear of anesthesia. So let's talk about anesthesiology.
Well, I'm glad that you're bringing that up because it's a very important point. As an anesthesiologist and as anesthesia providers, we actually are perioperative physicians. So we're taking care of the patient from the preoperative period, the intraoperative period, and the postoperative period. As part of the program for mitigating all of these issues, including the fear, we like to have a discussion with the patients preoperatively to really engage them and give them the information and educate them about the procedure they're having, but also about the anesthesia. In general, anesthesia is fairly safe, but in terms of mitigating that risk, we do like to interview our patients and learn about what particular health issues they might have preoperatively. And we do something called optimization. So we optimize the patient to reduce that risk, whether it's a cardiovascular issue or a respiratory issue preoperatively. We figure out ways, in concert with the surgeon as well as other specialists, ways to prepare them for surgery from a physiologic perspective. What's so wonderful about minimally invasive surgery, as Dr. Donkor so eloquently explained, is that it helps to reduce or mitigate the physiologic stress that you'd otherwise have with a traditional surgery. So issues like an increase in blood pressure, increase in stress to the heart or brain, is less likely to occur if you have smaller incisions. So what we do in concert with what he's doing is formulate a specific plan for the patient to reduce their pain post-op, which can include alternatives to opioid drugs, opioid analgesics. Sometimes a nerve block may be helpful to block the pain in the specific area that the patient might otherwise be sensate. And as well, this reduces the amount of drugs that we otherwise have to expose the patient to. So it reduces, like he was saying, length of stay and overall complication, which is a huge benefit, a huge mainstay to doing minimally invasive surgery.
Well, you know, in our previous show with colleagues that are in your profession, we spoke a bit about, I guess you could say, minimally invasive neurologic interventional techniques. And talking about using blocks, they were saying to me that there's a lot more nerve blocks that are being used today because they want to avoid the use of opioid therapy. Is that something, you just mentioned it, but I know that the people out there, they're seeing it every single day on their television news, or they read about it one way or another. And we have this incredible overutilization of opioids to mitigate pain, but yet just in the practice of what you do on a daily basis, seeing a patient, I mean, you have to make decisions, and a lot of those decisions are based upon the, like you say, the post-operative issues.
Right. So communication is so important. So one of the things that we like to do when we're interviewing the patient and also speaking to the surgeon is making sure that we're managing the expectations of the patient. Number one, we may, based on the surgery, be able to gauge how painful this procedure will be, because some procedures are more painful than others. Number two, if the patient had prior exposure to opioids or is a chronic opioid user for chronic pain, for instance, we may develop a specific strategy to reduce the pain, because pain does produce anxiety, but if there's a plan, we're able to help mitigate that anxiety. Back to the nerve block issue. Nerve blocks today is not just spinals or epidurals. What we've been fortunate to do now is a lot of nerve blocks on the periphery, whether it's upper extremity nerve blocks, meaning those blocking only the arm or part of the arm, or part of only the lower extremity, part of the leg, or only part of the leg or lower part of the leg. We're able to basically find a nerve using ultrasound technology. So we use an ultrasound machine to only block the site that might need to be anesthetized for the procedure. Now, bringing it back to minimally invasive surgery, if a patient is having abdominal procedure, there's also blocks that we can utilize with the ultrasound machine to inject numbing medication, the side of the trunk, as well as anteriorly or the ventral part of the abdomen to help reduce that pain.
Well, Dr. Donkor, let's get back to you. Getting back to this minimally invasive technique, do you use a robotic procedure as well?
I do a lot of robotic surgery. Actually, my fellowship was specifically training in robotic surgery. So robotic surgery is just is another platform to complete minimally invasive surgery. The difference is that robotics versus general laparoscopy is robotics is a surgical platform with high definition 3D visualization, and also the ability to articulate the instruments with your hands. Although you're not at the patient's bedside, you're at a console. It really helps you to complete very complex surgical dissection and surgical procedures that most likely would need to be done open.
Let's get this. I repeat it many times during the shows when we talk about robotic surgery. It's not a robot that's standing next to the patient. It's you, your knowledge, your training,
yes,
your hands.
Definitely. Patients ask me that all the time. They say, "Doc, are you going to be in the room?" "Doc, you're doing the surgery, right?" "Yes, the surgeon is doing the surgery. It's simply using a platform to have the ability to, almost like you have your own fingers within the patient to do the surgery. And that's the difference between laparoscopy. Laparoscopy, the instruments are very rigid, they're long, and they don't have the ability to articulate and move your fingers in such a way that you can do very difficult, intricate dissections.
Yeah, and again, I want to stay on that for just a minute because people don't recognize, again, when people think of surgeons, all right, or when people think of anesthesia, they're always thinking about, oh, they're putting something over my nose, that's it, or they give me something in the arm, and that's it. It's not the way it is, and we'll get back to you in a minute, Dr. Semien. But again, with your hands are your mind and knowledge combined with what we have called hands. Mm-hmm. So whether you're using a robotic element or whether you're directly involved right there with an instrument, it's the same techniques, only as I understand it, and I think you just stated it, that the robotic nature and the utilization of the robotic unit gives a more precise element of surgical technique. Is that correct?
Yeah, you said exactly. So it's actually increased precision. One of the cool things about the robotic platform is it will remove the tremor. Everybody has a natural tremor. So when you get on the platform, it actually subtracts the tremor. So if you're dissecting around little blood vessels, or you're up in the esophageal region in the hiatus, fixing a large hiatal hernia, which I do often, it's very nice to be able to move the instrument, not have to worry about moving half a centimeter to the right or into the left and causing a major bleed. So it's very important. It's integral in doing very complex surgeries that before patients would be in the hospital for 6 days to 2 weeks recovering. Now they're getting out in 2 to 3 days because of the minimal pain effect afterwards.
Well, you just gave me an opportunity to get back to Dr. Semien because pain is the issue with anesthesia, both prior to, during, and after. It's all yours.
So one of the things that we do after speaking and evaluating the patient and speaking to the patient, developing the plan for anesthesia, is now we have developed a specialized pathway, a multimodal pathway to control pain. One of the theories behind this pathway is to really treat pain before it occurs. Okay, this theorem is named by different ways. Some people call it the wind-up theorem, such that if you inhibit the pathways that sends the pain up to the brain before the pain stimulus occurs, the patients who had that inhibition prior to have less pain than patients who did not have that inhibitory effect prior to the incision. So what we do for patients like Dr. Donkor's is give them alternatives to opioids prior to the induction of anesthesia. Medications such as Tylenol or acetaminophen, gabapentin, tramadol. These medications, plus others, depending on if the patient's a candidate, are ways to reduce the amount of opioids they would need postoperatively. And he hit the nail right on the head when he was talking about essentially return to function. So the real goal, aside from having a successful surgery, is to be able to return to your baseline function earlier. And not exposing patients to as much opioids allows that to occur. Opioid use is associated with sedation, dizziness, and postoperative nausea and vomiting, but also gut dysfunction, so constipation, ileus. These are all complications that can be associated with gut surgery. And so if we're able to reduce the exposure to some of the other elements aside from the procedure itself, then we do that. And doing minimally invasive surgery, robotic procedures, in concert with alternatives to opioid analgesics really helps us to achieve that goal.
You know, and another thing to both of you, again, the patient, as you say, it's the preoperative communication with the patient. You're the new generation of not health professionals, but techniques that you have been given knowledge to apply to these individuals. And anesthesia is really a very important issue to making, with all due respect to Dr. Donkor's capability, but a lot of what you would be doing in your world of anesthesia mitigates the anxiety ex post facto of the work that Dr. Donkor does. And I think it relies upon your communication with Dr. Semien and his people, and enables ex post facto or post-operatively the communication they give back to you, saying, gee, it was terrific. You were wonderful. And they may not even know what the anesthesiologists were doing because they take it for granted. Oh, they're going to put me to sleep. I'm not going to know. But the truth is that you're mitigating a good deal of the back talk that would come, the pain alleviation issues. Am I in the right cue here?
Definitely, and we actually discuss and communicate during the case intraoperatively. So if I'm getting into bleeding, or I'm having a difficult dissection, or I'm saying, listen, I need to make some of the incisions a little bit bigger, I'll let them know. If I have to open or I have to do something that's going to cause more pain, they'll say, okay, you know what, we're going to do a block after. Is that okay? Do you have any issue with us doing a block? And they'll say, no, please go ahead. So, the better job they do, the better it makes me look, the better the patient feels, the quicker the patient gets home.
Well,
and if I might say,
yeah, go.
What's wonderful about what he's saying is that it's all true. He communicates so well, and it's so important in the operating room that we all work as a team. And what's wonderful about Dr. Donkor, and I'm not saying it because he's sitting here, but it's all about the patient. So because of his bedside manner, it sets up the stage for us as working as a team, because then he obviously has met the patient already, and then we are also representing the medical community, but also himself, or also Dr. Donkor, when we arrive and evaluate the patient and really put the patient at ease through conversation, because communication is also part of that pathway. Reducing anxiety, no matter how you do it, whether it's through medication or communication, it's part of a program to mitigate that physiologic stress to surgery. It's
part of the procedure. That's the way I look at it. I mean, am I on target?
Definitely, yeah.
Let me ask you relative to the OR itself. I know that I believe at Westside Regional, where you work, they have what I would call hybrid ORs now. In other words, there's not one specialty OR for this and one specialty OR for that, whatever. That there's a team approach to the techniques that are going to be used in this multiple service OR. Is that correct?
Mm-hmm. Yes.
Doctor?
That's correct.
Absolutely. Well, I got a quick, yes, that's too correct, so I have to go on to another issue. Let me ask you, Dr. Donkor, because there's a lot of, we've had a lot of questions about gallbladder issues.
Mm-hmm.
Again, it has a lot to do with, age, indigestion, a lot of things you talked about issues relative to esophageal problems, et cetera, but gallbladder seems to be one item that our viewers ask about quite often. What's with gallbladder stones? How does that happen? Why am I getting cramps? Why am I getting flatulence? What's the problem?
So that's a good question. Gallbladder disease is actually very common. So about 20% of the population actually have gallstones. But it doesn't mean everybody's symptomatic from those gallstones. So, being overweight, the diet that we have, we're not as active as we were before. obviously. We don't walk as much. We don't exercise as much. So all these things are factors that lead to gallbladder disease. And then, of course, an inherent problem within your biliary system and your gallbladder, where your gallbladder is not as active and the bile and this starts to form sludge and form stones. I think the important thing is for the viewers is to understand the symptoms. It's not just having a gallbladder attack that lands you in the emergency room with a 10 out of 10 pain with vomiting. It's the indigestion, like you said, the bloating, the feeling like you're full after eating certain meals, knowing that if you're going to have a burger and fries that you're probably going to have a rough night. Those are indicators that you may have a gallbladder issue. Obviously, there are things like irritable bowel syndrome and gastroesophageal reflux, and these things have very similar constellation of symptoms. But if you are having those symptoms, it's very important to go to your doctor and ask some questions and maybe have some tests done. Because we know that if we can take care of a gallbladder problem before it becomes an attack, you really are saving yourself from a very difficult surgery, possibly a long stay in the hospital, and then any other issues that may occur from it, such as pancreatitis and having stones falling into your main biliary tract system. So gallbladder disease is very common. It's something that if your diet is clean, eating healthy, low fat, low grease, you could probably get away with not needing the surgery if you have not become symptomatic yet. But if you are becoming symptomatic, then definitely we recommend to see a specialist who deals with gallbladders.
Yeah, in other words, the GI docs, the gastro docs, to see what's going on. And usually, I guess, the way they know is by either scanning or doing, I would assume, testing.
Yes, so what we do is when a patient comes to the office, we do a history, obviously a physical. You want to look to see if they have any color changes. Are they jaundiced? Do they have, are they icteric in their eyes? Any change in their color of their urine? If not, you continue with more of questioning any difficulty with certain foods, bloating, indigestion. From there, I would order some regular blood tests, and then, of course, look at your liver panel, see how your liver tests are doing. And then an ultrasound of your right upper quadrant, which would focus on the gallbladder, looking for stones or sludge.
Are the finding of stones, because we hear it often, that the doctors say, well, you have a few gallbladder stones and don't worry about it, leave it alone.
So that very good point, very important point. If you have stones and you are having symptoms, then you should see a specialist. If you have stones but you are completely asymptomatic and you don't have any issues, then it is okay to do what's called expectant management or observing. Meaning that, the next year or two, if you start to develop symptoms, you know what the symptoms are, you go to your doctor and then you ask more questions and maybe do some more investigations.
Well, we're down to the last 2 minutes of the show. And I think we've given the folks a lot of information relative to their questions.
If I could
Carl,
add in.
I'm with you.
If I could add in about the last thing is we talked about minimally invasive surgery. So gallbladder surgery is pretty exciting for myself because of the robot, I actually do the gallbladder surgery with one incision. So it started off with open, traditional, which is a long incision across the abdomen. And then in the 80s, we started with laparoscopic or minimally invasive, which 3 to 4 small incisions. And now with the robot, I'm able to do the surgery with one incision through the belly button, which is essentially scarless surgery. So recovery is very quick. Patients love the cosmetic result, and it's great because the surgery is routine and they do really well from it.
Very quickly, do you remove the stones or do you
remove the whole gallbladder?
Whole gallbladder.
Yes.
And then you have to, I guess, anticipate the need for the production of bile, so you mitigate that by the use of certain.
Well, interestingly enough, the liver makes the bile, and the gallbladder just stores the bile.
It.
So once the gallbladder is out, after a couple of weeks, I tell my patients, you'll go back to a regular diet, and you'll be able to eat freely. I would like you to eat healthy, but you definitely have the ability to eat.
Okay.
What you like.
Well, thank you, Dr. Donkor. It's a very important last subject matter. Dr. Semien, thank you very much. I wish you nothing but the very best. I know you come from a cold weather city where you were trained in Rochester, but Knowing that you're from the South, you'll get used to Florida real fast. We have very quick winters here, about 5 days, so don't worry about it.
I love it.
Yeah. Thank you very much. We
Thank you,
appreciate you being here.
Appreciate you.
And welcome to our community. And Dr. Donkor, welcome back. And we hope to see you again at some point in time. We have a lot of questions. People, most people don't realize, you're dealing with a community where we have the highest percentage of people over the age of 70, and we're the highest number of people, by number, over the age of 85. So, the body is meant to go on forever, but the reality is that a lot of things, they get caught up with some problems. So every once in a while, you got to see people like yourself that are capable, and someone like yourself that mitigates the problems that he inherits when he has to do surgical techniques. But thank you both very much for your talent and your knowledge and your advocacy. We appreciate you being here. Folks, I do hope that we answered your questions. If you have any other questions or you want to send us some comments, there's a email address right here. And there's a telephone number if you need to call us. Remember, this program is called Dateline Health. I always tell you that you have to take good care of yourself. And if something's bothering you, don't forget to tell your doctor. And you go to your primary care physician and they want to refer to Dr. Donkor, keep on telling them information. You might have forgotten to tell somebody. You forgot to tell them what product you bought over the counter, or oh yeah, I ate this, but I just remember, I forgot to tell someone. It's very important to let these people know so that they can use their knowledge to make you feel better. So again, this program is called Dateline Health. We come to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see ya.